Hey, how's it going? This is Dr. Siva here. I'm here to talk about another commonly discussed issue in clinic of the various graft options that are available for ACL reconstruction. So when we look at an ACL reconstruction, there are a variety of options for the graft that we can choose. The common grafts that we utilize are either using your own tendon, which is an autograft, or a donor tendon, which is also known as an allograft. Within the autograft section, which is your own tendon, there are a variety of tendons that we utilize, and we'll discuss these a little bit later. The first being a bone patellar tendon bone autograft, the second being a hamstring autograft, which I won't really go too far more in this talk because it's not a frequently utilized graft in my hands. And the quadriceps tendon graft as well, which can either be all soft tissue, meaning just lacking bone, or it can also have a bone plug as well. When we think of the ideal graft for an ACL reconstruction, the idea with the ACL is that with it unfortunately being unable to repair itself, we're looking for a substitute tendon or a reconstructive option. When we think of the ideal ACL graft, we want it to be biomechanically similar in strength and characteristics to the native ACL. We want something that's easily harvestable and something that's reproducible for every patient and every case. We want a graft that has the least harvest site morbidity, meaning that the graft or ligament that you take is not going to result in other problems resulting from the loss of that tissue. And you want something that's going to be long lasting and gets incorporated into the bone and becomes a new ACL for you. Unfortunately, to date, there really is no ideal ACL graft. And so when we look at ACL graft choices, we weigh the pros and cons of each graft. And this is where, when I think of a patient who has an ACL tear, every patient is a little bit different. And there are a variety of pros and cons to each graft. And each one of these pros and cons helps me determine on an individualized basis which graft is best for which patient, which is why it's really important to be comfortable in utilizing all these different grafts so that if the right patient comes in for the right graft, I'm prepared to, perform that procedure. The first graft that I wanted to talk about is the bone patellar tendon bone autograft. And so if you look at this schematic here, this is a AP or front view of a knee, and the BTB stands for bone patellar tendon bone. And so what we're doing here is we're taking a block of bone from the patella. We're then harvesting the central portion of the patellar tendon, and then we're also taking an additional bone graft from the tibial tubercle. And so the tendon graft is harvested from the patellar tendon with bone plugs on either side of it. I'd say that this is probably a workhorse graft for me, and I'll explain why later. So historically, and even today, we think of the bone patellar tendon bone autograft as the gold standard, in my opinion, for ACL reconstruction. It has excellent clinical results in the peer-reviewed literature and a high level of patient satisfaction. The primary advantage of it is that it's a very, very strong graft. It's what I would use for high-end athletes, people who are constantly testing their ACL from time to time. So it's really my preferred graft and my strongest graft, and it's a really, really good option for young active individuals. The other advantage of the bone patellar tendon bone is that it has bone on each side, and so bone likes to heal to bone. And so it allows for fast bone healing within the tibial and femoral tunnels. So I would say that in my hands, the bone patellar tendon bone autograft is kind of my go-to graft for young active patients for all of these reasons listed above. as I discussed earlier, nothing is free when we do ACL reconstructions. And so some of the cons with the bone patellar tendon bone autograft is that, because you are harvesting a portion of the patella as well as the patellar bone, there's a risk of patellar tendon rupture as well as patella fracture. The most common issue that people have with harvest-related morbidity is anterior knee pain and difficulty with kneeling. There are a lot of modern tools and techniques that I utilize to help limit the incidence of anterior knee pain and pain with kneeling. However, that risk still exists with this graft. And so again, this goes back to that earlier slide where, every one of these graft options, they have pros, but no graft is perfect. Despite these cons, I would say that this still is my preferred graft to date for all the reasons I mentioned before. My next most commonly utilized graft would be the quadriceps tendon autograft. And so this is that same schematic of the knee. The highlighted portion there is the central portion of the quadriceps tendon. And you can see, and if you kind of compare it to the earlier image, you may say, well, it's really, really close to the patellar tendon. And you'd be right. It's at the superior aspect of the patella is your quadriceps tendon. This schematic utilizes a harvest of bone, which is something that I perform as well. But more often than not, I take an all soft tissue quadriceps graft, and I'll explain why in the next slide. So some of the pros of the quadriceps tendon autograft is that you get a huge graft. It's a very, very large soft tissue graft. In my opinion, a little bit weaker than the bone patellar tendon bone, but still a very, very reliable graft that is quite strong. Biomechanically has been proven to be a really, really good choice, and for some surgeons is a primary choice in their hands. There is, in my opinion, a slightly less incidence of anterior knee pain and postoperative pain. And the reason why I believe that exists is because with the soft tissue graft, you're not having to harvest any bone with that. And so I think the addition of the bone harvest does add to slightly to a little bit more postoperative and anterior knee pain. Some of the cons, and in my opinion, the biggest con with this graft is that despite it being a really, really good and strong graft, you don't get that bone-to-bone healing that you get with the bone patellar tendon bone autograft. So here again, with the quadriceps tendon autograft, you're trading a little bit less fixation for a lot of bit more pain. And so I think this is a good complement to the BTB, and is another good option for young active individuals as well. The third graft that you consider for ACL reconstruction is the allograft or donor tendon. And so this image shows a variety of donor tendons. Again, donor means it's from a cadaveric patient, a patient who's passed away and has donated their body to be utilized for these donor tendons. There's a variety of tendons that can be utilized. The four listed here are the posterior tibialis, the tibialis anterior, the semitendinosus, and the gracilis. And they, depending on the particular patient, we can choose which donor tendon to utilize. The advantages of the donor tendon, in my opinion, the biggest advantage is the pain after surgery. It has the least amount of postoperative pain. Donor tendons, because you're not having to harvest the ACL from yourself, has a much, much lower incidence in postoperative pain. From an incisional standpoint, it has the smallest incisions. And the biggest advantage too is that there's no harvest site morbidity, meaning that, unlike the quadriceps tendon where you're taking a portion of your quadriceps tendon, or the patellar tendon where you're taking a portion of the patellar tendon, you're using a donor tendon. So you still have in continuity all the quadriceps and patellar tendon. The biggest con of the donor tendon is that it's the weakest graft option. It's still a very good option for a large majority of patients though. There is a small risk of donor-related infection. That's been reported to be literally 1 in a million. These grafts are sterilized and irradiated versus frozen, depending on the manufacturer. So while there is a risk of donor-related infection, this risk is very, very, very low. I've never seen it in my practice. And that's probably the biggest pro and con. I would say the pros are that it has a very, very fast return to recovery, and at least in the early postoperative period. It has the smallest incisions, but you're trading that for a slightly weaker graft compared to the bone patellar tendon bone and quadriceps autograft. So this video is an animation of an ACL reconstruction. We'll start playing it right now. So this is a femur and tibia bone. We're looking at a mid-substance ACL tear. An arthroscopic shaver is being utilized to clean out the remnant of the ACL in its entirety. First, we drill a femoral tunnel, and there's a variety of options to do this, but in this video, this is a retrograde femoral tunnel that's being drilled. Next, a tibial tunnel is being drilled. You'll notice there's a passing suture there to pass our graft later as well. The tibial tunnel has been reamed in its entirety. Next, the graft of our choice is being passed first through the femur side, and it's sequentially tensioned using the particular implant in this video, and finally passed through the tibia. And so this is a completed ACL reconstruction with the tightrope implant as well. So that concludes my talk on ACL graft choices. My hope with this video is that it helps to clarify some of the questions that may come through in the office. And my hope is that this spurns more questions. And so if you have any further questions, please reach out to me, and I'm happy to go through this over the phone. Thank you for your time.